Yes, sir.
YouTube, huh?
Okay. Okay, sir.
Because some people not able to join, they want to hear. It's a very important topic.
Yes, they can see. Let's see.
Hindu, shall I start? 4 o'clock?
Yes, we can start.
Yeah. So, very good evening to everyone. Today, guest of the honor, Madam Evelyn P. Kannan, Secretary General, TNI. Our TNA EC member, Ms. Saini Chako, Co-Chairperson and Secretary, TNA Delhi Branch. And Ms. Bindu Saj, Coordinator, Chairperson, Nursing Education Section, TNA Delhi Branch. And Dolma, Moderator and Chairperson, Nursing Service Section, TNA Delhi Branch. And all the EC member of TNA Delhi Branch. And today, eminent speaker, Dr. Minnie George, Principal, College of Nursing, ILPS, New Delhi. And Seena Babu, Nursing Educator, ILPS, New Delhi. And all the participants and dear students, once again, good evening to everyone and welcome you all for 16th webinar on Empowered Nurses to Empower Nurses. As all of you know that we are doing this program since almost over 1.5 years. We have crossed almost 16 months and almost 32 empowered nurses. They came forward and they share their work, their experience and vision. That was the outcome of this program. When we decided, we discussed with my EC member, we are very happy to initiate this program. The reason behind it, there is a different factors which, help us to move further in the professional life. So one of the most important factor is, that is the motivations. That motivation we may get through the money or the promotions or maybe whom we are serving. That is the patient or community. The nurses and Indian nurses really have the faces, many things which is not, get it done. That's why they are moving to other country. They are become practitioner. They do so many things. But India, still there is a, lot of limitation to overcome these two factors, two things. Number one is the status and our salary. But one thing can be still retain us to make move. That is only by the motivation, self-motivation that we motivate through our service to the community and the patient. When the patient are satisfied, the community is satisfied, that will give recognition for us. So when these empowered nurses they are very unique. Today, Minnie George, Madam, Seema, like everyone who they are making every day the life of patients different, very beautiful. And they are not like others. They have their own creativity. They make the system in their professional, the practices. That's why they are making the title like nurse-led or some of the services very become unique for them. I'm very proud to say that I am leading my team, myself leading the Delhi branch. We are able to get many number of the nurses from Delhi and who are doing very great job. Earlier, everybody was, not knowing that each other. Everybody, maybe myself, maybe know, sometime others may not know that. So that we come to know through this, program. Like even today, you can see that the Madam topic, Minnie George and Seema, who combinedly working as an educator, administrator, and same time there is a practitioner. They work together as a collaborative manner. They make the new, I think this is, maybe I can say very happy to say this first time in India. I don't know about globally. I am first time hearing this nurse-led diagnostic. In trauma, they also doing with ultrasound nurse-led. It's first time I see this type of the work nurses lead that improve the outcome of the patients, because overall our objective to improve the outcome of the patients. That this all depend on, we believe that earlier by only doctors, but this depend on nurses. That is what they are proving through the independent practices. I'm once again, I'm very, we myself and everybody congratulate ourselves, because When we started this program, we thought that what we are going to achieve, but now we are so achieved, even including me. I'm inspired with this type of work and come to know by the work. Earlier, we used to only read literature. Now we are lively hearing from them. That make the difference of this program. And I congratulate the speakers once again also, because daily it is that it's a make the a different type of work, proud for every nurses. Because I usually say that one word, every nurses, whoever doing, they are make the difference. They are the really motivator for everybody. And they are with that belief that we are progressing. That also we are able to see that. So with that, I just want to once again welcoming everybody, and I over to Saini for proceed the further. Thank you.
Yeah. Thank you, Dr. L. Gopichandran, President TNI Delhi State Branch, for the welcome address as well as for the encouraging words. I bring greetings from the Trained Nurses Association of India, Delhi State Branch. It's my privilege and honor to introduce our eminent speaker, Ms. Seena Babu, who has done her BSc in nursing, and she is working as a nurse educator in ILBS, New Delhi. Let me brief about Ms. Seena Babu, ma'am's experience and achievements. Madam has a rich experience in the field of nursing education and clinical practice of over 20 years. She is a qualified trainer and has received certificate from Ecosense, France, for operating various type of Fibroscan machine and props. She's specialized in performing Fibroscan for the last 11 years, and she has trained more than 10,000. She has done more than 10,000 scans in a year. Ms. Seena Babu Madam is expert in training for healthcare workers and has taken lectures for more than 6,000 nursing professionals and nursing students for various liver diseases topics under ILBS project. Now, I request Ms. Seena Babu Madam to brief us about Fibroscan. Over to you, ma'am. Others can mute their mic. Linu Elsa Abraham. Bindu ma'am, can you mute?
Ma'am, unmute yourself.
Prashant, can you identify who is unmuted?
Madam can unmute yourself.
Good evening. Thank you so much for introducing me, and good evening, delegates and all the organizers and dear participants. Today, we are going to discuss about Fibroscan. Many of you may be knowing about it. Many of you may be operating it. So we'll share the experience about Fibroscan. Fibroscan is a scan of liver by a machine developed by Ecosense, that's from France, which utilizes a form of ultrasonography to measure the stiffness of liver non-invasively. It's a very important one to measure the stiffness of liver. As we learned in medical surgical nursing, and it is stating that cirrhosis of liver, that is in that case, liver loses its architecture. So the stiffness of measurement is very important for diagnosing a liver disease. These are the various Fibroscan machines. You can see there are probes. You can see M written and XL also. You can see the tip of the probe. It is very small. It's based on ultrasonography only, but the probe is different. So it is very small. It is small because it is we need to adjust in the intercostal space actually to scan the liver. These are the various machines we have, and the bigger machine which I have shown the right side, that is the new machine, and which is costing around 2.5 crore, and it is the latest one. In this machine, we can able to see the stiffness of the spleen also, splenic stiffness. That is also an important one. We are started from 2020 onwards. We have different portable machines which we use for the camp in different areas of Delhi. So we'll move. What is liver fibrosis and cirrhosis? Liver, this is very common thing. And still, liver is a vital organ that performs more than hundreds of functions. Any chronic disease, addictions, infections, and metabolic problems, and genetic reason also, and certain drugs related problems that comes under drug-induced liver injury, that is DLI, and other reason, prominent reason of the liver damage, that is CAM, that is complementary and alternative medicine, may cause the liver fibrosis, that knows the scarring of liver tissue. Later on, what happens? Can you hear me, ma'am?
Yes, ma'am. Yeah.
Yes.
Okay. So what happens? Normal liver is very soft. When we press it, it will loses its structure actually. In that way it is. So what happens? The above said problems that is affecting liver for long time. Some problems are effective for the short time, like certain drug-related liver injury, otherwise CAM, complementary and alternative medicine. What it actually, it is like Ayurvedic medicine also comes in that, Unani also, and some Chinese medicines also what we use, like even home remedies. I'll emphasize on this thing, CAM. It's very important nowadays because during the COVID time, we used to take giloy juices and aloe vera juices for the immunity boosters. So we have that patients and long-term use of this, patient end up in, lot of patients end up in fibrosis of liver. Many of end up with the acute liver injury also. I know around 5-6 patients underwent transplant also related to acute liver injury because of the CAM intake, mainly on bottled giloy and other giloy juices. Every day they make at home and use. So these kind of things that leads to stiffness of liver. Actually, liver should be soft. It adds to stiffness of liver. Initially, we say it is a fibrosis, that is a scarring of liver tissue. Then that turn to what happens? That turn to a permanent damage. Then later on, that started hamper with the functioning, and finally that patient will end up in cirrhosis and end stage of liver disease. So how does the Fibroscan work? Fibroscan machine uses a probe almost similar to an ultrasound probe, which is kept in the right lower chest wall of the patient, because we know the liver is located in that area. By pressing a button in the probe that sends a shear wave, that's ultrasonic wave only, to the liver, what happens that vibrates the liver and detects the stiffness of liver. This happens in seconds actually. And this data is automatically transferred to the onboard computer, and the liver stiffness is displayed on the screen. So we need to take 10 such readings and that to be recorded, and the result is delivered at the end of the 10 acquisitions, that too in kilopascals, kPa, with an IQR. IQR is known as interquartile range, that shows the accuracy of the report. In the manual says it's less than 30% is accurate, and here in ILBS we keep less than 15% to more accurate. And the successful rate, that is 100%. These are technical terms actually, and the result is delivered in the kilopascals, kPa. So in this way, we are the Fibroscan procedure is done. Additional facility with the Fibroscan, other than the liver stiffness, that measures the quantity fat content also of the liver. So that is known as control attenuation parameter, CAP, CAP. That is control attenuation parameter, that indicates the fatty liver. Earlier, the first machines and all which we had in the time of 2008 to 10 period, we don't have this facility. These recent all machines have this CAP facility. That means along with the stiffness value, we can be able to understand the CAP facility. I mean, fat content of the liver tissue. So positioning and preparing of the patient. I joined with ILBS in the year of 2008. Until 2010, I was assisting doctors for this procedure. So my work was positioning the patient, explaining the report to the patient. And after 2010, what happens? My former director, he came after a conference and he said, "I'm going to teach you Fibroscan. You have to do it, and it is outside of abroad and all. The nurses are performing this, so I teach you." And he taught me that, and after that I trained a group of nurses and who is working with me in Fibroscan. So we people are managing the department actually. So how to position and prepare a patient for scan? Patient lies on his back, right arm is raised behind the head. I already explained it is through the intercostal space. So while raising the hand in the back of the head, what happened? The intercostal space we get it little more wider to adjust the probe enough in the good window. And the measurement is made through the intercostal space. No preparation is required, preferably on fasting 2 to 3 hours after a meal, because heavy meal can overestimate the stiffness. How it is overestimating the stiffness? Because after 2-3 hours of food intake, what happens? The blood supply to the liver will be comparatively increased. The vasculature of the liver will be comparatively increased compared to the other time. That is why there will be a minute chance of overestimation of the result. That's why we avoid taking patients within the 2 to 3 hours after a meal. So this is the and the preparation. And about the probe, three type of probes are available. One is medium probe that we use for the normal adult, and next is XL probe that we use for the obese adult, and small probe we use for the children. And there are two versions available in the small probe itself. S1 probe that we use for the children less than 5 years, and S2 probe that we use for the children less than 14 years, 5 to 14 years. This is the algorithm based on the age algorithm. We'll not be able to follow it all the time because, especially for children, there will be the liver disease child will be emaciated one. So we will not be able to follow the age algorithm always because the child will be very small. In that time, we'll adjust the probe size according to the child's body structure. So this is about the probe. What are the normal value of Fibroscan? Normal liver stiffness. That means very normal one. Liver does not. If liver is very smooth one, that is the value should be less than 6 kPa, kilopascals. The fibrosis stage, I have explained fibrosis, the reversible damage. That stage is from 6 kPa to 11 kPa. Next, what happened after 11 kPa? The cirrhosis will happen. That is in the irreversible damage, otherwise a permanent damage, that is from the 12 kilopascals. The maximum stiffness can be measured through this Fibroscan machine, that is 75 kPa. In that case, the patient will be having all the decompensations, symptoms, and the patient will be in the end stage of liver disease. So this is about the Fibroscan stiffness. Now coming to the CAP, control attenuation parameter. The normal CAP value is less than 200 decibel per meter, and the maximum range that is 400 also. So here in the Fibroscan, we stage accordingly like the percentage of fat accumulated in the liver. The 400 that shows the 100% of fat accumulated. If it is less than 200, we say it is normal liver without fat. So fatty liver diagnosis, knowing fatty liver, that's an important one because nowadays it is the leading cause of liver disease actually. That is the combo package, like when metabolic problem, diabetic and fatty liver, we see as a combo package. So this is the leading problem for the liver disease. So the CAP measurement, otherwise fat measurement, is an important one. Next, what are the indications for Fibroscan? Fibroscan is we are doing for the patient for workup of incident detection of hepatitis B and C, and before initiating antiviral therapy. Why we are doing it in the initial time? To know that how far the liver is damaged due to this virus. This will take a lot of years to damage. It will not happen all of the sudden. There are cases it will happen all of the sudden. In the case of hepatitis E mainly, and sometimes with the A, that is acute liver failure. It will happen within days actually. But for the hepatitis B, if it is not reactivation, in that case patient will have high jaundice and all. In that case, it will happen in the liver failure within days. Otherwise, usually hepatitis B and C, it will take years to damage the liver. It has a graph. It will progressively damage the liver. It may take 15 to B and C. It may take to 15, almost 15 to 20 years to damage the liver actually. So to see the initial damage stage, we do the when the patient is detected with hepatitis B and C, we do the Fibroscan, and before initiating initiating the antiviral therapy. Sometimes we will not initiate the antiviral therapy next day of the detection. We wait for the viral load to come, and it is in a suitable stage when we have to see the SGOT-PT level also, and then we start. It may take, maybe keeping a patient for gap for therapy. So before starting the therapy also, we do the Fibroscan to see that how the graph is going, how it is declining. So next is monitoring through the antiviral therapy to see that how it is improving. Okay. Next, for the workup of fibrosis and cirrhosis of liver. Other than the hepatitis B and C, if the patient is having any other issues like liver related symptoms, to know that whether this patient is falling on the fibrosis stage or cirrhosis stage, we do Fibroscan. Next is prediction of decompensation in a stable cirrhotic patients. We broadly classify cirrhosis in two ways. One is compensated cirrhosis and the decompensation compensated cirrhosis. Compensated means the liver is maybe having cirrhosis. Liver is having cirrhosis, cirrhotic liver, and patient can pull on the functions. The liver can pull on the functions, and patient will not have much of like symptoms like the peculiar symptoms of the liver damage, like hepatopulmonary syndrome, hepatorenal syndrome, and you can ascites, otherwise any hepatocellular carcinoma and all. This will be a stable stage. Stable cirrhosis can pull on the functions, even the cirrhotic liver. Next, what happens? There is a stage, it will start damaging, it will start giving complications like bleeding, like ascites and many things, other multi-organ effects. And this all will happen in the case of decompensation. So when we get a Fibroscan in for a stable patient to certain level, and after that it start deteriorating, it will go high. In that way also, this Fibroscan will help us to know the unstable cirrhosis. Next is for assessing quantity of fat through the CAP. I have already explained it. And for assessing liver status in patient with diabetic, obesity, and metabolic problem. That's an important one. As I explained, we do it for the health checkup patient also, and we do it for the siblings. Otherwise, immediate relative of a patient with fatty liver. I mean, the n number of liver diseases which we have seen in the first slide. The one is fatty liver related liver damage. What happens? It can happen in second generation also. So in that kind of patients, we screen the patient, we come to the diagnosis that this patient is because having cirrhosis because of the fatty liver. Then we immediate relative, like the children will screen because they'll be having a genetic reason. Okay, so next generation, they may have it very early. So that is the scenario which is happening nowadays. So we, because of the lifestyle, so we screen for the immediate relatives, I mean, mainly children, and we included in the health checkup package also to see that the community will be screened for this. And we conducted, as I said, we conducting camps in different areas to screen this, to screen the society people to see how their liver, whether they have the fatty liver, otherwise any other issues, and how is the liver, stages of liver, whether it is good or bad. Next is alcoholic patients suspected to have cirrhosis of liver. So this is a difficult thing. Actually, most of the time, patients will not carry their, prescription paper, otherwise patient file with us. So once we do the scan, we'll come to know that they have a high value. Then we ask for the history. So it's very difficult to get a history of an alcoholic patient. Firstly, they will deny. So they say it is a social drinking, and after 2-3 times, we repeatedly ask because performing Fibroscan is the easy one. Once we know the technique, it's easy to perform. And what happens? The difficult part, there are n number of reasons which lead to a liver disease. So we need to correlate the patient condition with our report. For that, we need a knowledge. We need a vast knowledge about liver disease. So what happens? We need to ask the patient a lot of questions. So finally they deny. So later on they will come repeat after asking repeat questions. They will come to know that the alcoholic patient and this alcohol has damaged the liver. So this is very easy one. So and they will get a, they will take it guarantee also once it is okay, I can continue with alcohol. This kind of conversation we usually get in the Fibroscan department. Next, indicated as a part of pre-transplant workup in both donor and recipient. Ours is a transplant setup, actually, ILBS. So for the transplant workup for the donor, already recipient might be undergone this before. For the workup of the donor, we put in the primary assessment. We have included Fibroscan. We'll get a status of the donor liver. So that will help us to screen the donors. Next is assessing the risk factor of hepatocellular carcinoma. What happens in cirrhotic liver? Once the normal liver, fibrosis, next cirrhosis, then what is next? They will end up in the hepatocellular carcinoma. So once we do the fibroscan, actually the fibroscan will not tell you directly about the hepatocellular carcinoma, but that will give an idea about hepatocellular carcinoma, hemangiomas, any lesions, any parasitic infestation, any type of SOL. SOL means space occupied lesions. It will give an idea about it. So this is an important, fibroscan will help us to know about hepatocellular carcinoma also. Pre and post assessment of vascular procedure. That's an important one. We have a good vascular department. When we do the vascular procedure related to liver and all the portal vein and all. So what happens? Sometimes patient will end up come with all decompensated symptoms. The decompensation I have already explained. Liver patient will have bleeding, ascites, and all edematous body, and all this like all other symptoms like deranged of complete LFT, and this kind of albumin is very low. So we'll have all symptoms, and the report is also suggesting cirrhotic liver. But usually liver may be a smooth liver. This supply to the liver is from portal vein and hepatic artery. So what happens? The vast circulation from this portal vein. So what if any obstruction in the portal vein, that shows that the liver is very stiff, because the vasculature to the liver will be restricted in the case of portal vein occlusions. In that case, what we do, we put a stent in the portal vein. We unblock the problems. In that kind of vascular procedure, pre and post assessment through the fibroscan is very important one, because it is a non-invasive one, and that will help the diagnosis of the patient as well as for the treatment and the improvement prognosis of the treatment. And next, the final one, that to know the splenic stiffness. I've shown a new machine, and that gives a splenic stiffness value also. Why splenic stiffness is important? Because portal vein kaise banta hai, that's from the splenic vein also will join all the abdominal organs from the abdominal area will join together and make a portal vein. It's a huge supply to the liver, actually venous supply. So what happens when liver is cirrhosed? Otherwise, any occlusion in the portal vein, what happens is the whole blood will go back to the different organ. So the first one, they will go to the esophagus. There'll be bleeding esophageal varices, and the splenic type. Normal spleen is very small, and it is not palpable. Also, it is just anatomical review when we do. It is just occupied inside the other organs. Actually, just chupa rehta hai. What happens? The splenic stiffness will increase once the portal hypertension happens, because the backflow of the blood. So spleen will be enlarged. So splenic stiffness measurement is also an important one. We are doing it from the 2020. ILBS is the first setup to measure the liver stiffness. And we were the first one to measure in India. We were the first one to perform the fibroscan of liver also. And we do almost around 150 patients in a day. So I'm adding to one more thing, and that administration of ILBS has given full authority for the nurses to managing the department. None of the other person other than the biomedical and IT, they never interfere anything. That department is managed. We have 2 machines every day running, and we have other machines we're using for the camp. No interference, nothing. It is fully nurses managed department. And with it, madam is going to explain about the accuracy of the nurse-led fibroscan. You will come to know how we are performing. So these are the indication of fibroscan. And what are the benefit of fibroscan? It is non-invasive, because for the prognosis, earlier we used to do the biopsy. And nowadays also, we need to do the biopsy to some extent. I am coming to that point, but now it is a non-invasive one. We can repeat it. It's based on ultrasonography. And it is a safe procedure. It is quick and time-saving. and replace biopsy to some extent. Why to some extent? Earlier, we used to send the patient for biopsy to know the liver stiffness, otherwise to know the extensive of liver damage. So what happens in after Fibroscan came, so we're able to see the liver stiffness. But some patients, for example, when a patient is having diagnosed with hepatitis C, and that patient is having alcohol-related, chronic alcoholic intake also, to see different differential diagnosis, we need to see that which is the prominent reason of liver damage. In that condition, we have to send the patient for biopsy. Next is very easy to perform, as I explained. It is, the technique is very easy. Only thing the difficult thing, we need to understand the patient condition, and we need to correlate the report with the patient condition. For that, we need to understand the patient condition and the disease. We should have a vast knowledge about patient disease condition. No need of rest after the procedure. We can patient can walk up within 5 minutes after the test. These are the benefits of Fibroscan. Constraints of Fibroscan: pregnancy in 2 to 3 trimester, because as we know, in the first 2 trimester, it is okay because the uterine size will not be much big, and after 2-3 trimester, and the uterine size will increase and all the organs get jammed inside. We will not be able to focus the liver. Otherwise, we will not be able to. We will not get a good clear window for the scan actually. So that is why pregnancy is contraindicated after 2 to 3 trimester. But one more thing I need to add, most of the hepatitis cases, hepatitis B and C, is detected in the first 2 trimester, right? So that is needed. We can able to do in the antenatal, first antenatal checkup, the patient comes with hepatitis B and C, we will able to do it. Next is morbid obesity. We have an exercise machine for the obese patient. We did a patient about 180 kilogram of weight for the pediatric surgery. But there are some cases patient is having morbid obesity and the weight distribution is not equal. The weight is in the abdominal area. In that time, when the patient lies down, all the weight come to the liver side. The abdomen will be sagged to our sides. No, in that time we will be having a difficulty. And patients with ascites. And you may be thinking that ascites itself is symptoms of cirrhosis of liver, but it is not. Liver is not always a culprit for ascites. We know that a lot of other things like secondary carcinoma, metastatic carcinoma, like otherwise ATT. There are a number of other things like we started a new medicine. It may reacted and a patient will have ascites. So when we need to, it is difficult to perform a patient with ascites because the fluid will block. When we press the button, the wave will go inside and it will bounce back because of the fluid collection. We will not be able to do for the gross ascites patient. For minimal ascites patient, we will able to do with an Excel machine. So these are the constraints of Fibroscan. I think by this I am ending up my presentation, and I would like to thank you all organizers to given me the platform for this presentation, especially Minnie George ma'am, because she proposed me for this and she guided, supported, and otherwise it was not my chance actually. And thank you so much, ma'am. And all of my colleagues working with ILBS Fibroscan department, they are doing a tremendous job. I'm very happy to say that nurses are performing such a wonderful job. My team members and my mentor in ILBS and Madam Cicely Babu, and especially my administration of ILBS. Thank you so much.
Thank you, Madam Sina Babu ma'am, for explaining about Fibroscan. Initially, I thought it was something related to fibroid and some scanning about that. But after your class came to know that it is a scan of the liver and also the spleen stiffness. So thank you, ma'am, for explaining us about Fibroscan, its indications, its benefits. And I'm also proud that the nurse is handling this Fibroscan. So proud to be a nurse, and congratulations, ma'am, once again. And now I request Madam Bindu Shaiju, Madam, Chairperson of Nursing Education Services of TNI Delhi State Branch, to brief our next speaker, Dr. Minnie George. Over to you, ma'am.
Yeah. Prashant, can we have the slides, ma'am? the other slide. Dr. Minnie George. Yeah, it's my privilege to introduce our next speaker. She's a very eminent speaker, Dr. Minnie George. She's currently working as a principal in College of Nursing, Institute of Liver and Biliary Sciences in New Delhi, where our previous speaker has now just talked about Fibroscan. And we are really proud to have both the speakers in this forum to speak about the Fibroscan, especially, which possibly most of us might not be knowing about as well. And to introduce Madam Minnie George, she carries a rich experience of over a decade in the field of nursing education, research, administration, and she has also worked in the overseas in the clinical practice. She has a certificate for neonatology course from Royal Hospital, Sultanate of Oman. She's a master trainer of baby-friendly hospital initiative, lactation service, prevention and management of childhood and diarrheal diseases in children. She's also a master trainer for prevention and management of malnutrition in children. She has presented research papers in national and international forums, been expert and chairman in reputed research committees, as well as the academic boards. She's been an organizer, chairman, and resource person for workshops, conferences, seminars, both in national and international forums, as well as published research papers in index journals of repute. She owns membership in various professional bodies like the Neonatal Nurses Foundation, European Neonatal Nurses Foundation, as well as the TNEI, NRSI, CMEI, etc. We're really glad to have you, ma'am, in this forum. Over to you for your session.
Thank you, Bindu. And I take this opportunity to thank the organizers, especially the TNI Delhi branch. Here I would like to highlight the fact that this kind of opportunities that you people give us helps, as Dr. Gopichandra sir was just telling us at the beginning, helps us get audience, people get to know what work we do, and we can also learn from many things from others in the audience. So I would take this opportunity once again to emphasize that we are really honored and proud to be here. And when asked, I said, this is how we will go about, because ILBS is a platform where both the service side and the education side works together. And students are in the clinics all the time, and people like Seena Babu and others in the clinical side, they help students along with us to gather their theoretical as well as practical experience. Now, having heard Seena Babu talk to you for the past half an hour, I think it needs no emphasis that you'll agree with me that you can, from her passionate way of talking, you know, she has been working in this area. It was in 2010, as she said, she was called forward to embark on this journey of learning Fibroscan and doing it. And mind you, nobody knows about this earlier. No nurse has done it before. And she was confident, and she's a bold person who took up the responsibility, learned it, and she was the first person to be certified. And now, after her, there are many more, 4 or 5 more staff who have joined, and she has also been influential in training them, and she even today guides all of them. And as she already told, they are the ones who are running the clinic without anybody else as part of the diagnosing team, meaning to say that there are no doctors or any technician. It's exclusively these nurses who do the scan, they give their interpretation, and the whole diagnosis and treatment is based on their report. So you can imagine how well they must be performing that function. Now, the second part I would like to say is this study that I'm going to present here is done by Ms. Sanju Kumari. She is also there, I think, in the audience. And when we embarked on, and I guided a study with her. And when we embarked on this journey, we realized the amount of work these nurses have been doing, and they are the unsung heroes, and many people don't come to know. And since 2010, this clinic has been going on, and we really wanted to know how this clinic is functioning. And we have presented this paper in the Korean Digestive Disease Week. It was selected. She presented it. So it shows the caliber of the study, and it's already under publication in a PubMed Index journal. And what I would like to, so we thought the last leg of the whole thing was to introduce this group of people who are really working at the back. It is their work that we are projecting to the world. So I thought it's our duty to ensure that people know about them. Having said this, I would go into my topic here. So I would like to thank them also for having given us it. Only when we started working on this study that we realized such a yeoman job is being done, and we need the world to know it. And this is the title of the study which was done. It's a diagnostic accuracy of a nurse-led fibroscan, and we are going to talk about the ILBS experience. And what you find is, once thought to be a rare disease, liver disease is now the cause of significant morbidity and mortality. And as she just said, when we know there is a liver disease, we need to stage the liver disease. We need to know in which stage the liver disease is, because that helps in the disease management. And we also heard from her that liver biopsy is considered the golden standard for staging. And the Fibroscan is competing with this golden standard to establish itself. And we also know there's a rise in the burden of the liver disease, and we need this rise emphasizes that there's a need for specialized workforce who's competent to deliver care. And that example you will see when you come to ILBS, that we have specialized competent workforce, as in this case, who take care of these kind of patients. So once though thought rare, why do we say that it's important is the factors that are leading to chronic liver disease. The leading factor is alcohol, and what you will find is there are around 2 billion alcohol users. Of them, around 75 million are alcohol use disordered people who could be leading to liver disease. Another contributor is viral hepatitis. Viral hepatitis has always remained a high contributor. And the third one, which is coming up, what you see is the changes in the lifestyle, which also she emphasized. Obesity, which is 2 billion people suffer from obesity now, and 400 million suffer from diabetes. Combined together, they lead to non-alcoholic fatty diseases. Alcoholic fatty diseases is your first contributor. The third contributor is your non-alcoholic fatty liver disease. And the fourth contributor is drug-induced liver injury due to over-the-counter drugs use, constant use or chronic use. And she said about CAM and other drugs, complementary drugs that may be taken, like other drugs like ATT, your anti-epileptic drugs. All these are contributors to DILI, that is drug-induced liver injury, the four main contributors. And so liver disease is on the rise. Second stage we said is liver disease staging is important. We need to know the stage of the disease, which helps in the disease management. So we know that knowing that stage of the liver disease helps to guide in the treatment and predict the prognosis. For both, the staging is necessary. And we have also come to know that liver biopsy is considered the normal standard for staging. And what happens with both liver biopsy and Fibroscan confirms the diagnosis of types of liver diseases and assesses the severity of the disease. Having heard from Sina, you will know that Fibroscan is non-invasive, liver biopsy is invasive. It has complications, and sometimes the amount of specimen that we get from the liver biopsy may not be adequate enough to give you a proper result. And specimen should be more than 1.5 centimeters. It should have more than 8 portal tracts. Unless all these are fulfilling, your liver biopsy may not be useful. So, it's painful. Patients are put under a lot of complications. So, Fibroscan is considered an upcoming, or it's already procedure which is taken precedence. But mind you, again, while liver biopsy cannot be totally avoided, there are instances where liver biopsy is at most needed, which also she has explained in the previous talk. Now, this rise in the burden of the liver disease, I said we need special forces. And as I've just explained, ILBS has been running a nurse-led Fibroscan clinic since 2010. They are all certified nurses, and the team lead is Seena Babu, whom you heard just now. And there is no published data on the diagnostic accuracy of these nurse-led Fibroscan. They've been doing scan, but there are no data which says how accurate is their Fibroscan. No previous study in India has also validated the reliability of nurse-led Fibroscan in staging fibrosis. So this led the researchers to conduct this particular study. And herein we are going to see the what was the purpose. The purpose of our study was to examine the diagnostic accuracy of the nurse-led Fibroscan, or also called as the transient elastography, in staging fibrosis among the CLD patients at the Liver and Biliary Sciences Institute. The hypothesis that we tested was there is no significant accuracy in the liver stiffness evaluation by the nurses, nurse-led Fibroscan in staging fibrosis, as compared to liver biopsy at 0.1 level of significance. The second hypothesis that we tested was there is no significant correlation between nurse-led Fibroscan in LSE is liver stiffness evaluation. The stiffness of the liver is being evaluated by the Fibroscan, and the staging by the short form LB that I have given is liver biopsy. So how well both these tests are correlating. We say the null hypothesis that there is no correlation, and later we test it. Now, if you see the design that was used by us was a retrospective single center study. The setting of our study was the Fibroscan clinic and the Amadi of ILBS hospital. The sample was total enumeration of the charts of CLD patients between January to December 2019. And this study we are reporting here as per the reporting standards of STARD, that is the standard for reporting diagnostic accuracy study guidelines have been used. Now, what if find the scale that we used was, we didn't have a made scale, so we developed it. So we developed a data abstraction sheet by having interactions with the hepatologist and many people involved in the Fibroscan. And then this sheet was developed, and the content validity was checked, and you can see it was 0.9 or above. And even the interclass correlation and test retest reliability were all above 0.9. So the scale was deemed valid and reliable, and the scale was used. The scale checked as liver stiffness evaluation KPA, that is kilopascals of, this is the Fibroscan measurement. Liver biopsy has many methods of measurement. We used Ishak staging. Demographic variables like age, gender, BMI, Asian Pacific cutoff we used, and the clinical variables. We also checked the time difference between the Fibroscan and liver biopsy. This I would like to clear it for the audience that this was necessary because if the Fibroscan and the liver biopsy are done within a span of 6 months, they are reporting the same level of fibrosis. If they happen to be above, the difference happen to be above 6 months, then we are not staging the correct time, meaning to say fibrosis could have increased over time or decreased over time if the gap of these two tests happens to be more than 6 months, so they cannot be compared. So for comparability, this was taken. And the data collection, the ethical statement, we got the IRB approval. Then the hospital has a policy of taking patient consent at the time of admission to use anonymized data for research purposes. So, and we assigned only study numbers on their abstraction sheet, no patient identifiers. We also de-identified the data abstracted so that it cannot be tracked back to any nurse or a healthcare worker who performed which scan. All these things were de-identified as per the guidelines. So we did a tryout. Tryout helped us on 10 records. We did a tryout. It helped us find the feasibility and practicability of the scale, which took around 20 minutes each in each case. And a pilot study helped us in finalizing data management plan. How will we manage the data? How will we analyze the data? Now, this is how the charts were filtered out between the January to December 2019. We had 809 liver biopsy reports, and after removing the problem specimens, then we got around 346 liver biopsy and Fibroscan reports were identified, which were within 6 months of each other. And data related to the Fibroscan was downloaded from the Fibroscan machine at the clinic, and removing 132 failures or invalid reports. Finally, we got 193 charts which met the inclusion and the exclusion criteria. And the chart was reviewed and data was extracted to get LSE values, the liver biopsy value, demographic profile, and the clinical profile. Then the data analysis was, the data was verified for its normal distribution. Analysis was performed on SPSS 25 version. All tests were two-sided at 0.01 level of significance. The frequency and percentage were calculated for categorical variables, mean and standard deviation for continuous variables. Sensitivity, specificity, and accuracy was the main test that we did, which checked the accuracy of the test, how to describe how good and reliable is the nurse-led Fibroscan. So the watch out for this slide for sensitivity, specificity, and accuracy. Then we also plotted an ROC curve. A ROC curve was plotted using the sensitivity and the specificity data. And the Spearman's row correlation between LSE, that is liver stiffness evaluation, and liver biopsy was compared. Okay. And the results are, this slide just shows the demography of the CLD patients. You find that above 41 years were the patients, maximum of the patients. Gender was more of females. Those the slide data has gone down. Obesity in BMI, you found that most of the patients were overweight or obese. If you look at their clinical characteristics, you find that the percentage is given. Jaundice was at most, portal hypertension was 91%, ascites, so it's going in a decreasing order. Variceal bleeds, coagulopathy, hepatic encephalopathy, so the percentage goes down. And the clinical diagnosis, if you see, so the various etiology which led to fibrosis, that CLD, ethanol CLD NASH, we have arranged it in that sequence in which higher the number are on top, so which means CLD ethanol is more than CLD due to delay. So like that, these were the type of the clinical characteristics that we saw in the patient. And now comes, this is the most important table. This is the accuracy of the Fibroscan in comparison with the liver biopsy, which is the golden standard. Here, if you see that the Fibroscan report and the liver biopsy report has been divided into two, that is the significant fibrosis and advanced fibrosis. Significant fibrosis, the scores given by Ishaq score, we kept it between 3 and 6, and advanced fibrosis between 5 and 6. And LSE cutoff was more than 8 kilopascal, and as significant fibrosis, and advanced fibrosis more than 12 kilopascals. Now look at the third column is the true positivity rate, and the next column is false positivity rate. So what you find here is the true positivity rate is nothing but sensitivity, which was 0.84. Anything above 0.8 is considered highly significant. And for the advanced fibrosis, the true positivity rate is 0.81. And the false positivity rate in significant fibrosis is 1, and advanced fibrosis is 0.88. So all these four are above 0.8. The AUC values below, and the interpretation is given below. And you will find that the accuracy, AUC is nothing but accuracy of their scan. You find that it was 0.93. The range is given, and 0.89 for advanced fibrosis. So you find that for significant fibrosis, they had 0.93, which means it was excellent. The report was excellent. For advanced fibrosis, 0.89, almost reaching 9, was very good. So this table shows that at 0.01 level, the nurse-led Fibroscan report, when compared to liver biopsy, was excellent when it comes to significant fibrosis, and very good when it comes to advanced fibrosis. So which means their report is almost near equal to a liver biopsy. And this was plotted on a graph. If you see the graph, sensitivity is on your y-axis, and 1 minus specificity on your x-axis. And there is a diagonal going, a red color diagonal going. If your points fall on that, it means that the test is not a good test. But here it shows as a good test, because you find that the sensitivity and specificity, the blue graph, is going very nearer the left line. The more it nears the left line, shows that the diagnostic test is more sensitive and more specific, which means it's more accurate. And it goes and joins a line on top and reaches the right line here also. So the more the line is nearer the left or your y-axis, if the graph was, for example, somewhere here, that shows it was a poorest test. Whereas this graph is very nearer the y-axis, and it's going and touching it at the corner on your x-axis, which clearly shows that there is a big area under the graph, and which goes to show that this test was very effective. And this is, we are talking about, I think the cursor is not moving. The test was significant. The data that we the data that we just saw in the previous table, now we are showing in the form of a plot. It is plotted. So what you see, ROC curve to test the LSE in staging significant fibrosis shows that it is a very accurate test. The next figure also, you find that this is an AOC that we have used to test LSE in staging advanced fibrosis. Here also you find that it is more nearer to the y-axis, and finally goes and touches the x-axis at 1. So which clearly shows that there is a big area under the curve, and its proximity to the y-axis shows that the test is uh, very good. So we saw that the test for significant fibrosis was excellent, and the test for advanced fibrosis was very good. And now, when the third or the next table that we put up was the correlation, rank order correlation. The LSC fibrosis, the no fibrosis, there was 40. Significant fibrosis, there were 153 patients. As per liver biopsy, when you see no fibrosis, there were 24 patients. Significant fibrosis, there were 169 patients. And this Spearman's rho was calculated, and you find that it's 0.763, which is also highly significant at 0.01 level of significance. This also goes to say that the nurse-led fibroscan is almost accurate or highly significant when compared with the liver biopsy result. So which means they have been doing a great job and a tremendous job of being able to bring it as close to the liver biopsy results. And that is kudos to nurses who have been doing it for the last 10 years. So the first thing says that the fibroscan requires a minimal training, and nurses will be able to perform scans quite validly. 100% they are able to perform. And you find that the nurse-led fibroscan had significant accuracy, sensitivity, and specificity in staging fibrosis. It could replace even the liver biopsy. That high was the accuracy, the sensitivity, and specificity of the nurse-led fibroscan. 93% and 89%. It was almost reaching that of the liver biopsy. And we also find that the correlation between, there was a strong positive correlation between fibroscan and liver biopsy. So if you see the discussion part, the first one of our result was minimal training was required. And what you found here is, as in our institution, where nurses performed fibroscan independently after 50 supervised and proctored scans, other studies also indicated the same. By the 50th scan, they were able to reach 60% validity as per Armstrong study. So this study was also in concurrence with other studies. In the current study, 5 nurses handle the fibroscan clinic, easing the load on the clinicians, as was seen in another study by this El Gohari et al. Yet other studies found that nurses can manage 90% patients in the primary care, reducing secondary care referrals. If at primary care itself, if nurses can handle it, we can avoid patients going for a secondary referral. And liver care delivery was enhanced when nurses did it. People uptake of liver services also was higher when nurses did this scan. There was 67% acceptability as per Matthews et al. Study. So which means it was similar to the findings of our study. Nurses were better equipped at handling fibroscan. The patients liked their services better. Patients came for liver service cares better when nurses were handling the fibroscan. The next one you find is, like in this study, this study was in sync with other studies in the sense that nurse-led fibroscan showed significant accuracy and sensitivity and specificity while staging fibrosis. It was found reliable. Like our study, Few et al. Study also found that nurse-led fibroscans are very reliable. They're accurate in detecting and staging fibrosis as per Gaussier study. And we find that it was fibroscan, nurse-led fibroscan was one of the most accurate of the 9 invasive tests that is done. And it could avoid liver biopsy in majority of the cases. And it could diagnose twice as many cases as usual clinics. When doctors or technicians perform in other clinics, better than that, nurse-led clinics diagnosed it twice better. And in primary care, it enabled even detection of fibrosis in healthy adults. So all these are similar to the findings of our study. And nurse-led, the third main result of ours was that nurse-led Fibroscan had strong positive correlation with liver biopsy. So in staging significant and advanced fibrosis, compared to liver biopsy, the sensitivity and the specificity was high and significant. Specificity was slightly higher than the sensitivity. So in this study, Fibroscan was better at ruling out and ruling in fibrosis, and as was seen in other studies too. So it ruled in as well as ruled out. If a diagnostic test is considered to be good, it should be both able to rule in your diagnosis as well as rule out. So when you do a sensitivity test, when it is high, it rules out. When a specificity is high, it rules in. So what you find is this both were the case in our study. It was both highly sensitive as well as specific, and specificity was also high. When both these are high, accuracy increases. This was shown in other nurse-led Fibroscan clinics also. Again, I would like to emphasize here, these are all Western experiences where there are studies of Fibroscan, of nurse-led Fibroscans, nothing comparable from India. So a few Fibroscan clinics of abroad, only very few studies, but our study also seems to be in concurrence. Now, the strength of the study was, we found that it lies in our meticulous execution of the methodology. The diagnostic accuracy of the Fibroscan was compared with the golden standard, that is liver biopsy for staging CLD or chronic liver disease. Some of the limitations that we could think about it. It was a retrospective study. The data was already collected for other treatment purposes. So blinding, to ensure blind reporting of the LSE and the liver biopsy was not possible, because clinical information and results of liver biopsy was already available to all the practicing people. So being a tertiary hospital, there could have been a selection bias. We get very advanced fibrosis here. So more of the cases that we would have included in our study could have been of more advanced fibrosis. And future researchers, if you see, it's a single center study. So multi-centered researchers are needed for further evaluation. Prospective cohort studies could be done. We did a retrospective, so prospective ones could be done. And cost analysis study also can be done to see how nurse-led clinics are most cost effective. Though informally we know that it is cost effective, but it needs to be established through studies how cost effective it is. So these are some of the future studies that can be done. And to conclude my topic, I would like to conclude by saying that given the increase in liver disease, more nurse-led clinics need to be started in many other centers also. This gives the potential for early diagnosis. Patients don't have to wait, early detection, intervention, and improves care outcome. And introducing such clinics is not difficult. So nurses can be trained, and our experience have shown that nurses are very much trainable, they are very capable, and they are able to perform it. Nurses are integral to liver care delivery system. So with minimal effort of capacity building of nurses, the pressure piling on clinicians and the system can be eased. Nurse operated data is available on the scan machine, which can be used for individualized learning and development. So each nurse can learn from their mistakes or learn to be more proficient because their data is available on the scan machine, and they can use this for their learning and development. These efforts in turn, why are we doing all this? In turn can improve the patient experience of, otherwise as liver disease is increasing, we find that patients are in queue. They are waiting for many months and time to get themselves consulted and get the care. So they will have timely access to specialized care, and the care becomes more coordinated, and there is better care outcome. So I think our experience at ILBS, we have shared with you today, and I hope it might have encouraged many of you out there who are sitting and listening to us. If you have any queries related to having nurse-led clinics, especially in Fibroscan, you could always approach us, Sina Babu here also. So we would be only too happy to help you with capacity building or any such thing, because I think nurses are very much integral to many of the care delivery system, and we can make a difference. When we make a difference, patients benefit, and their cost comes down. They timely get specialized care. And with that, I encourage everyone to do that. Young nurses who are listening to me today, remember that you can make a difference, and find your area of specialization, and try to bring in as many nurse-led clinics as possible, because patients out there are waiting for you. And with that, I would like to conclude my talk, and I thank everyone for your patient listening. Maybe some part of AUC curve and other things could have been a bit difficult, but I hope I conveyed the message. So once again, I would like to emphasize the nurse-led clinic here is doing a very credible job. They've been able to do they're excellent in significant fibrosis staging, as well as very good in advanced fibrosis. So which goes to say that even if we would have compared a medical led Fibroscan, technician led, I don't think we would have got that kind of a result. So I'm proud to be a person presenting it on behalf of my student who did this study. And I did it with the intention that we need to bring out these unsung heroes who work behind the scene. And I very humbly present this data, because we just presented it as a study, but the data belongs to them who have been toiling from 2010. This is the smallest that I could do for them. So with that, I thank you one and all, and over to you, organizers.
Thank you, ma'am. I think that was a very elaborate session with Sina Babu ma'am talking about the Fibroscan. I think Minnie George ma'am has brought about the evidence itself, to prove that how Fibroscan is effective over the other invasive techniques. And I'm sure that, ma'am very well took us through those stages, of why a nurse-led Fibroscan clinic is so much significant, is important, and why nurses need to be trained on this line. She talked about the liver disease. In the earlier times, we thought it was a very rare condition, but now it's one of the major cause of mortality and morbidity. And she took us through the importance of staging the liver disease in the disease management, and the very fact that the liver biopsy is the golden standard, but it's an invasive technique. And to utilize a better and a non-invasive technique like a Fibroscan, we need to test it and see how effective it is through evidences. And she has brought about a very good study, which she has been a guide for that student. And I'm really appreciative of you, ma'am, of promoting, your student to endeavor into such a study, which others have not embarked into. And she has very well put forth the result of the study, showing that, the accuracy of Fibroscan over the liver biopsy, where she proved two results. Nurse-led Fibroscan has significant accuracy, sensitivity, and specificity in staging fibrosis, as well as the nurse-led Fibroscan has strong positive correlation with liver biopsy. And we are really grateful to you, ma'am, for that wonderful, elaborative presentation and attesting it with that evidence. Thank you, ma'am, once again. And I think since we are running short of time, we would take some of the questions which have been posted in the chat box. I think if Madam Sina is here, the questions I think are mostly posted on her behalf for her. Madam Sina, if you could be here. One of the questions that has been asked is about the charges of the Fibroscan in ILBS. What is the charge of Fibroscan?
Charges of Fibroscan, that's for Fibroscan liver, that is 1800. And for the spleen, that is 700. And which is very cheap in Delhi.
Okay. Okay, so is there any other units, other than ILBS having Fibroscan clinics?
There are clinics, but they charge more, and again, the accuracy, we see the report, and since we have good experience in this, we could able to understand what is not correlating with patient case.
All right.
So better you can send to your patients, you can refer your patient to ILBS. Our clinic is, department is open from 9 to 5 o'clock. And you don't need to take an appointment. You can walk in and you walk off after 10 minutes.
Yeah. And I think then another question is posted by Sonu Yadav. I think, Madam, you had talked about one of the constraint of Fibroscan, that is obesity, morbid obesity clients. So in regard to that, there's a question for morbid obesity clients, can't we use a reverse Trendelenburg position or tables like that we use for bariatric surgeries, which might help extend the abdomen and put the weight away from the liver? Can we use those for Fibroscan?
No, patient should be on flat position only for Fibroscan, because we are going through the intercostal space actually, and that to the mid-axillary line. So it has to cross it. The wave should pass through the entire liver actually from the right lobe. So we cannot do that. And we are doing for the post-transplant patient in this left lobe graft. And for that patient, we tilt towards the right side little bit. Otherwise, we go directly to the epigastric area for locating the left lobe graft for the transplant patient.
Okay, so that only that position can be used.
That is.
Yes. Yes. Another question is how frequently is the Fibroscan performed for patients on antiviral treatment?
Antiviral treatment, I have already explained. At the time of detection, we can check it during antiviral therapy, and we don't need to check it actually during viral therapy, because for the hepatitis B, the therapy for long term. For the hepatitis C, it is for just for 3 months, otherwise 1.5 months nowadays. So we need to do only one scan, the starting and after ending. For the hepatitis B patient, we do it after every 3 months. They want. Otherwise, if the SGOT, PT, everything remains normal, that's a chronic one, and it will not damage the liver very soon. So we will keep 3-6 months in that sort of gap.
Okay, and what is the course that is given to the nurses to train them for the Fibroscan? Is it a certificate course, or how long duration is required to train?
It is not a certification course. The nurse assigned for the Fibroscan, they will work with us. They observe, and later on they will be given a chance to perform Fibroscan, and we will be doing the final Fibroscan. And that way we train them, and ultimately the EchoSense, the company, gives a certification for handling the machine and probe.
If I would chip in, I would like to say, ideally 10 are done directly on the patient along with the hepatologist or the operator from the EchoScan, and then the later 50 are supposed to be supervised, meaning while it's being done, it's only supervised. After that, your scan machine has all these readings. If that Excel sheet is sent to the EchoSense people, they will be able to look at it and give you a certifying. But again, everybody cannot walk in and do that. It has to go through institutions like us.
Okay. Okay. I think that is the questions that have been posted in the chat box. If anybody would like to unmute and ask a question, that's also you're free to do that as well. If anybody has question that you have not posted and you would like to ask in this forum, either to Minnie George Madam or Sina Babu Ma'am. Anybody? I think the session was well explained, and everybody has understood. I understand from that. And thank you once again, Seena Babu Madam, as well as Dr. Minnie George, for taking your valuable time and being here in the TNAI forum to share with the nurses and empower them. And I'm sure that whatever they have taken today, whatever the sessions they have taken and primed today will be, taken forward. And I'm sure that, many nurses in this forum would be challenged to take up roles, extended and expanded roles of this type ahead. We are really encouraged, ma'am, by your sessions, both of you, and TNAI Delhi State Branch and TNAI Headquarters are really appreciative and thankful to both of you for being with us and empowering the nurses in this forum. Thank you, madam. And we also want to thank the EC members who are here, our Secretary, Madam Shaini Chaku, and our President, Dr. L. Gopichandran, whose vision is what we are formalizing in this platform. We thank all the other EC members who have joined in this Zoom, and also the participants, without whom we cannot actually disseminate the information. We are really thankful to everybody, and thank you all once again. If you don't have any more questions, we close the session for today, and have a good evening and a wonderful day ahead.
Thank you. We are also proud and honored. Thank you, Anana.
Okay, thank you, ma'am.
Thank you, ma'am.